Today, yes, we are here to talk about health care reform in a nutshell. That is this morning, to talk about kind of the ABCs, make sure that everybody understands just the general lay of the land for health care reform, what has happened, and what we're in the midst of, the current state of play, what we can look forward to in 2014, and then on the horizon. So very ABCs this morning for the next hour. Then in the next session, myself and Bruce Schroeder and Peter Altman from the Summit Law Group, we will take a deeper dive into the healthcare law and get more into practical application, practical strategies, which I know many of you are interested in. So I know some questions along the way are so welcome. Many of you who know me know that I'm informal. I love your questions. Usually when something's on your mind, it's also on the mind of someone else in the room. So please don't be shy, and we'll address those as we go. So that's our goal, that's our agenda. Let's go ahead and get started. So since the law was implemented in March of 2010 by Congress, and actually it was two laws put together, the original Healthcare Patient Protection and Affordability Act, but also a Budget Reconciliation Act. So it was a conglomeration of two laws that made our job as analyzers of the law quite challenging. And so we've been working through that. There were certainly acknowledged at the very beginning a lot of holes in the law, and those holes were intended to be filled by regulations as the years went along. This has been an incremental timeline of implementation. So from 2010 to 2018, there has been incremental change or reform to our healthcare delivery system. The intention was to hit every aspect of health care. And I'll address that in the next slide. But in essence, since 2010, we've all had incremental change occur in our healthcare life. We've had our plan design change. That was a very early mandate of the law that required us to eliminate our lifetime maximums. So we saw those lifted. It actually turned into an annual maximum, but after each year, the annual maximum would renew. So lifetime maximums that used to be $2 million were then placed into an annual maximum of $2 million, but that would renew the next year. So that healthcare plans had a little bit of time to react with claims and cost impact. In 2014, we'll talk about how that's completely lifted and there will be no lifetime or annual maximums on plans. So benefit plan change like that has been happening since 2010. 2011, we saw a lot of those mandated changes to our plans. 2012, we saw not a whole lot of activity, some W-2 reporting that had to happen that year. 2013, we'll talk about that in more detail in the coming slides. 2013 is the year of accountability, when all of us will be required to be insured either as individuals or as employers to insure those who work for you, the year of accountability. In 2015, 16, 17 and 18, again, incremental change, but a little bit of a gap between 2014 to 2018. We're going to work towards what people have been calling the Cadillac tax in 2018. We're definitely going to spend some time on that. Not as much time during this session. We will definitely spend a considerable amount of time in the next session talking about implications of the high value tax and how we can maybe work towards or avoid that tax as public sector employers. So that's been the timeline of the healthcare law. And as I said, it really intended, and this was a laudable intent. I think everybody in this room, regardless of your political affiliation, would agree that the system we have today is not sustainable. We as employers have not been able to sustain, even prior to the law's implementation, the double-digit rate increases of our healthcare system. And whoever you are insured through, here in Washington State or even nationally, no one has been immune to that double-digit rate of increase, 3 to 4 times the rate of general inflation, back to back to back. It's just not sustainable as a trend. So some kind of change needed to occur in order to make healthcare accessible and affordable in our nation. So the thought was that, well, change needs to happen, and no one is going to be able to avoid the change. So in the law attempted to impact change in all of these areas. Consumers, so those of us who are insured or not insured who access the healthcare system, a greater personal accountability for how we do access the healthcare system. For providers, so these are doctors, hospitals, pharmacies, durable medical equipment providers, having greater accountability to that trend line than what they do today. Some would say that this is the weakest part of the law, that this part of the law did not have enough power in it to influence change. I would have to say that I agree with that. And I hope that we can influence greater change. Maybe a little bit later on in the session we can talk further. Well, in fact, we can talk about it now. I think there's a really good example of something we came upon in Washington State just in this last month. The consolidation and integration of providers. So we've seen providers, particularly hospitals, have to band together, they feel, in order to better provide care to their community. What's been an outcome of that, though, is monopolies. And those of you in Skagit, Whatcom County, as well as Cowlitz and Clark County, were very intimately involved in this with regard to Peace Health, right? Peace Health, who has a complete monopoly of the hospital and the physician network in Skagit, Whatcom County, and also the islands, was going to opt out en masse of Regence Blue Shield. And not that this, and by contract, Regence Blue Shield was not allowed to say how much the rate of increase was being asked. 30%. When 31% of claims are made up by hospitals, the trust fund would have had to increase its rate increase by 9 additional percentage points to pay for that increased hospital cost. So that kind of trend, I think we'll continue to see, because we have more and more consolidation occurring at the provider level. So thankfully, I'm very, very thankful that Regence Blue Shield was able to negotiate its contract with Peace Health. Also, those in the Longview, Kelso area, also as direly impacted as Skagit, Whatcom County was, and also Clark County to some limited extent. The next contract coming due with Peace Health is Group Health. It's right around the corner. We had the Franciscan Health System also attempted to opt out of the contract, also asking for a fairly sizable increase, and they too have a great monopoly on hospitals. I love how yesterday during the Center for Quality Communities, there was a young woman who's involved in rural health, in hospital health, and I think this is an area that is just scarily on the horizon for problems, and that is rural hospitals are going to find it very difficult to survive. They have for a long time. And this may very well break the camel's back with regard to rural health. So I think that's an area too, as those of us in benefits administration, very concerned about that. You, as you know, local communities, wanting to make sure that your citizenry have access to good health care. This is a very, very important issue. Rural health is very different from metropolitan hospital services. So it's something that we need to pay attention to. Insurers, gosh, it's so easy to beat up in insurance companies, isn't it? They're the whole problem with this mix. Yeah, it's easy to lay a lot of blame in that corner. Now, I have to say that there's many that do warrant that blame. You know, we happen to work with, we've kind of encountered some, but I feel today the people that we work with are nonprofit. They're really interested in working towards health care in certainly our state and regionally. And I think there are some good companies nationally to work with. So provider reform or insurance reform is good, but it's also important to know that they can be a good partner in helping us to move forward. Employers, so this is all what you're concerned about too. What's the impact? So employer reform was certainly addressed quite heavily, and we'll talk specifically about that in great length. Attacking new strategies. Public sector has had rich benefits. We're known for rich benefits. We have rich contributions. Cities in particular have very rich benefits. Particularly comparable to other public sector county and state employees. We have very rich benefits and rich contributions towards those benefits. Difficult quandary in that we have obligations through union contracts for a lot of those benefits too. So it's very difficult. I see a lot of nodding heads on that one. Yes, and believe me, we will talk about that impact later this morning. So government, they themselves did not proclaim themselves to be immune. So you've heard a lot about some Medicaid and Medicare cutbacks, cutback and provider reimbursements. This is going to be extremely interesting to see how this plays out. I'll give you an example. Medicare as a provider reimbursement has been cutting back, and some doctors have been considering, do I continue to take Medicare patients? Fred Hutch has, they are just been impossible to deal with from a negotiation standpoint, and they have opted out of the Regents Network, and there's no continued conversations. They are done. It's huge. Fred Hutch is Seattle Cancer Alliance is a huge and well-respected cancer treatment center. It's not that there are not other very well-respected cancer treatment centers, but that's a significant one. Like I said, this trend is going to continue. And just as we had that kind of trend happen when, some of you might recall, when doctors were participating providers and this new thing called a preferred provider contract was out on the market, right? And doctors were saying, well, I'm not going to sign that preferred provider contract because they're not paying me enough to see that patient. So the difference between a preferred provider contract and a participating provider contract is just the rate of pay. Same doctor's office visit, same treatment and diagnosis code. They were just getting less for the same doctor's office visit. So they refused to sign preferred provider contracts. Today, employers had to move to preferred provider plans because it kept their premiums down, right? So it's what you needed to do as employers to keep that premium affordable for you. So what happened? Doctors are business people, right? So they said, golly, my patient, my clientele is leaving, I'm not getting as much money, I think I'll reconsider that decision not to sign that preferred provider contract. Today, you see virtually no difference between a preferred provider contract and a participating contract. In fact, they don't even offer participating contracts anymore. The preferred provider rate is the going rate. It's possible that we may see that same thing happen with Medicare. Because remember, the baby boomers coming up, who is going to be this huge bubble of use and access of health care? It's going to be the baby boomers coming up, and they're going to be Medicare age. And we don't have a huge population behind it, right? So I don't know, that's just a kind of a guesswork on my point. Maybe I'm simplifying it a little bit too much, but I think we might see the same thing happen. But it's not to say that there won't be a lot of pain before we get there. That's some years down the road, but it's definitely a cycle that could happen. Okay, so I'm slowly immersing you in my world. Are you? So, because you don't deal with this every day, right? So it's, I just want to make sure that you're kind of along for the ride. This is the kind of things that I think about and lay awake at night about. Actually, it's very, very fascinating stuff, frankly. So the future of U.S. healthcare coverage, this is what we're attempting to do from a very high level. We're expanding or improving coverage, so that's the left-hand side. And there is paying for that expanded coverage, right? So we open up the net for all, but how do we allow all to afford it? Who's paying for that for those who can't? So in the kind of tan-colored bubbles, we have direct employer impact. We'll talk about that. The blue bubbles are indirect impact. So, some of the things that are going on in healthcare reform, and I'll talk about them, they kind of indirectly impact employers. They might, though, directly impact you as elected officials. So I'll make sure that we touch on that. And then paying for expanded care, you'll see that there is a direct and indirect impact in the green bubble. And we'll spend some time talking about the taxes or penalties, as the U.S. Supreme Court had to decide, is it a tax or is it a penalty? Right, so ultimately it's some money being paid to cover care. So in healthcare reform in 2013, and again, please don't be shy if you have a thought or question. I know a lot of you, I know you're not that shy, so I know that you'll chime up as sooner or later with a question if you have a thought or such. Okay, so healthcare reform in 2013, this is what we've been living with this year, and some of you may be very intimately aware of many of these. The first and bolded item, and I'm going to spend a little bit more time talking about this, quite frankly, for the impact in 2014, but in 2013, we have had to address the full-time employee definition. I know many of you, and frankly, are probably in the room just to get answers on that. Am I right? Yeah. Along with the Cadillac tax. I think that's probably the motivator for being here. So the measurement period for full-time employees, particularly variable hour and seasonal employees, starts July 1. Of this year. So that's why many are concerned about making policy and identifying groups, is because it's really here and now. And although we have been talking about this since 2010, it's that this was coming and that we needed to prepare. The regulations to more clarify what we needed to do were latecomers to the game. And we've had 3 waves of them. Just as soon as we thought we had the definition of full-time employee down pat, they sent out a next wave of regulations. And so this has been a very difficult topic to get your arms around, but I think today we have a pretty good feel for this. So I think we're going to be able to give you some fairly good guidance in this regard. So more to come on this, but know that this is something that we're dealing with in 2013. We are required this year to notify our employees of the healthcare exchange. which when I get into this a little bit later is so ironic because our employees are not eligible for the health care exchange, but we're required to notify them of the exchange. So how confused are they going to be when they get this notice? So what we're going to do, and those of you that are insured through the trust, we're going to take care of this for you as much as we can. But if you're not insured through the trust, I highly encourage you to take the notice and put a Mr. Yuck sticker on it. And say, that yes, we're required to notify you of this law. It's required of us as employers, but you're not eligible to enroll because you have minimum essential coverage that is affordable by definition of the law. So because our public sector employers, and I'm just going to make that broad assumption for all of you, that you do, but we'll go over it just in case there is someone who might not meet that definition. But most of you, I'm pretty confident, do, that your employees are not eligible. So we are going to get that notice. That notice, model notice, ironically came out while we were at the Labor Relations Institute doing a session on this. So it's funny how the regulations, I think there was 2 of them that came out. Our speakers were on their cell phones, and the regulations, they were getting blipped as they were speaking. So that's how nimble we've had to be on this topic. The model notice is out. It needs to be issued to our employees by October 1st. So I know for the trust, we will let you know at the time that we send the notice out, but we're going to time it a little bit closer to open enrollment. I think that will make a little bit more sense to them as an employee, frankly, any employee. Yeah.
So you're sending the notice out to our employees?
Correct.
The employer, HR, department of our various cities don't have to worry about that?
The only thing you would have to worry about is sending the notice to part-time employees that we don't know about or insure. And so when we send out the notice to our trust employers, we'll let you know that this is the notice we're sending out to your employees. If you have any part-time employees, even if you don't provide them insurance, you're required to notify them as well. And here's the notice, you can send them directly.
We'll get an email or something.
Yep, you will get an email from us. Yep, all right, good. Okay. But those of you that are not insured through the trust, I think the model notices are out there. Your own benefit consultants, I'm sure, are on top of this big time, and they're working with your HR departments to get that rolling. And again, I think everyone's slant here is to send the letters out closer to open enrollment, which for all of us really is January 1, and open enrollment is typically in September, October. So probably sending it out in September makes the most sense to most. Okay, so we did have a limit on flexible spending accounts. So any of you that had limits that were above $2,500, you needed to reduce those limit for the health FSA down to $2,500. That was a requirement at the beginning of this year. The elimination of the deduction of expenses of the retiree drug subsidy, I think there's several large self-insured cities along with the employee benefit trusts that apply for this. I'm not going to go into it because for most of you it really doesn't apply. But if someone has a question, I'd be happy to address it. The high income wage earners had an increased taxes that the employers were responsible for. And again, we had very few that fell into this category. There were some employers of public sector that needed to pay attention to this, but for the most part not. So I won't go into a whole lot of detail about that. The second to last bullet we did need to pay significant attention to, and that was the further clarification within preventive care regarding women's health. So there were some benefit plan changes that we needed to make as of January 1st, particularly, for instance, any birth control or birth control devices needed to no longer have a copay or apply to a deductible. So that was a change that impacted, and that impacted marginally some benefits. Frankly, what's a travesty for me, and sometimes I go on a soapbox, I apologize in advance for that. I think the pendulum swung just a little bit too far to one side, and we're forgetting about men's health. And so that's a plan that I have to address in 2014 on our program. I think that we need to pay as equal attention to men's health as we do to women's health. So we will definitely take care of that for 2014. The last item I know has been talked about quite a bit, and it's called the PCORI fee. The PCORI is the patient's, I got to turn my pages to make sure I say this right, Patient Center Outcomes Research Institute. So this is a research study fee that is focused on outcomes or quality health care in the law, and it was a $1 per member per month fee that was due will be due July 1st. The trust, if those for your jurisdictions that have been with the trust, we're taking care of that fee. We will continue to take care of that fee. It's just embedded in the rate for us. And those of you that are self-insured or outside of the trust, I'm sure you've been taking care of it with your respective insurance carrier. If not, that is something that you need to pay attention to for this year. So it's $1 starting July 1 this year. It's $2 next year. One of those fees. Yeah, Glenn?
One question I have on, obviously, dealing with the federal government, there's the reporting requirements. We as cities don't have to send off that we have done this, 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 and this. We've notified of this. I assume you do it as a blanket reporting for all your employees, as opposed to everyone, or how that?
Yeah. So Glenn's question, if you couldn't hear it, is that as employers, and I think specifically employers of the Employee Benefit Trust, is there a requirement by someone to report that this fee has been paid by those employers as a part of the trust?
Or all the other things that are on the list.
Or all the other things that are on. Yeah, there is accountability to USDOL and the IRS for those that are insured through the Employee Benefit Trust. We've been taking care of that for you. And then those of you that have, you're fully insured or self-insured on your own, that's a requirement that you have directly to USDOL or the IRS for particularly the PCORI fee. I will mention an interesting phenomenon about the PCORI fee is related to health reimbursement arrangements. HRAs, and boy, this is another topic I get on a soapbox for a while on, but HRAs, particularly in the Pacific Northwest, have been used not necessarily in the manner that they were intended to be used. And so there's quite a bit of money built up into some of these HRAs, which are tax-exempt accounts of money monies that can be used on a tax-exempt basis. They're supposed to be employer funds, and they are identified as employer money, even though in a bargaining contract you might have employees who are contributing. Regardless, it's employer money, it's employer contributions. And it is considered a health plan. So all of those things have very, interesting outcomes because of that. For instance, the HRA is primary to Medicare. That was a bit of surprise for those who have an HRA, and how those monies will spend down at that point in their life. And then also with regard to the PCORI fee, because it is a health plan, it too is subject to the $1 or $2 fee. If you have a self-insured health plan, to some of those of you who I knew are self-insured or fairly large, you would only have to pay one fee. Because you're self-insured, a health plan, and if you have an HRA, you only pay one fee. If you're fully insured, your insurer is paying the fee, and then you have the HRA responsibility. Through your HRA, you'd also have to pay the fee. So you're frankly paying twice. So that's just something to pay attention to. I was going to talk about that a little bit more in another slide, so I'll come back there. But it's certainly something that you need to pay attention to. I think that most HRA administrators have been very good about notifying their employers about this element of the fee. And so I think those of you in the room who do have HRAs, hopefully that is the case. If you have any questions, please feel free to ask now or ask later privately. I'd be happy to chat with you more about that. Yeah.
Before slide, could you give us just a very short answer of what the ACA considers a high earner, high income earner?
Oh, I don't have those off the top of my head. I could get that answer to you. I believe it's 150,000 or more. I think, is that right? That was my guess, but I hate to give such a guess to a very specific answer. I can get that answer back to you.
Does one of your previous slides, the one with the timeline, say, or is that a different?
Yes. Yeah. Exceeding 200,000 for individual, 250 for couples.
Thank you.
Yes. Thanks, Pam. And there's a question over here.
So all of these things that you're doing for us, reporting and that sort of thing, is there like, we're going to get like a monthly report or an annual report as to what things you've done for us, so we can make sure that, you know,
Kind of checklist.
somebody asks us, we have that list as well as what we did.
Absolutely. So the question was, will you be getting us as employers of the trust a kind of a checklist or an accountability of what we've been doing on your behalf? Yes, it's definitely in my intention to do that. I've been working on it for a little while. If I could be at my desk for 2 days, I think I can accomplish that. And you know this about me, I have a really hard time telling you no. When coming to visit with you. So I love coming to visit with you and being on the road and presenting, but it does take me away from my desk to be able to write as well. So I do hope to carton off some time to definitely do that. My intention is in the summer to do a kind of a healthcare reform summer edition, and it's going to include a checklist. We're actually going to partner with MRSC, Pat's in the room, and as well as the AWC General. So there will be a combination of information on the AWC General website, the MRSC website that's appropriate. Oh, Tracy, hi. I'm sorry I didn't see you behind. Hi. And also the Trust website. So we hope to get more information out to you soon. And we have been communicating on a regular basis. We do have a monthly newsletter electronically that we send out. It has been telling you what information we are doing, but I know that some employers have really wanted kind of that checklist, particularly now as we move into 2014, and it really is time for that checklist, so we'll make that happen. Yeah.
When you talk about the full-time employees, but the part-time ones are the ones where we need to give the notice to. With part-time employees, how do they consider within the healthcare reform a volunteer or like a non-paid interns? Where do they fall in? Are they considered an employee that we have to notify even though they're not paid?
Okay, so the question is regarding notification to part-time employees, and particularly the question is what about volunteer employees or interns? Are they considered to be employees? And I'm going to hedge my bets on this question a little bit, just ask for a little bit more time. We are researching the question regarding volunteers. And I think at any of you were at Labor Relations Institute, the specific question that came up was with regard to volunteer firefighters.
Stipends.
Yeah, or stipends.
Yeah, our volunteers receive,
Stipends,
stipends for each call they respond.
Sure. So for anyone really that receives a stipend, volunteer or reservist or whatever. Yeah, so that question we are researching further. We've got an initial opinion. I think we really would like to vet it out a little bit further before we give an official response. We're going to work with MRSC on this as well. And I just got an initial legal response on, while I was at the conference here. And I do want to vet it out just a little bit further before I respond to that question, okay? It's a fair one. I know many are waiting for it, but I want to make sure we get it right. It's very important to do that. Okay, you're welcome. Okay. All right, so moving on to 2014. So yes, this is the year of accountability, where in theory, unless you are, and I'll move through this in the next slide too, a Native American, a criminal, or an immigrant, you are required to be insured in some fashion in 2014, whether it's on your own volition or through a private plan, a state health care exchange, or through your employer, you're required to be insured. As an employer, you have an obligation, most particularly those of you who have 50 or more full-time employees. I'm going to talk more about that in just a little bit. Roger, you want to question on that?
Off topic, the Native American, do you have to be an enrolled Native American, or is there a blood? What's the criteria?
What's the criteria of a Native American? I don't know the answer to that specifically, but I could certainly research it for you. Yeah.
Popped up and it just seems like.
I would guess it would be of the same criteria for receiving funding through federally to that level would be my guess, but I would need to research it further. Okay? All right.
May I answer?
Yeah.
I worked with the Yakama tribe for quite a number of years, and essentially what they require is the proof of at least a 16th
Yeah.
in order to.
Yeah.
It's now a quarter.
And it's on
quarter.
forward. Yeah.
It's a quarter to be able to be enrolled.
Okay. So, yeah, sorry, I was waiting for them to finish before repeating what they said. So John was indicating that you work with the Yakama Nation and that it was required to be a 16th, and that was going to be my inclination to answer. But Roger from Union Gap has indicated that it's now a 4th. So we can certainly, for those of you that are impacted, Pam?
It varies by tribe. as to what they-
Varies by tribe.
That's why I was bringing it up, the question, because
Yeah. Yeah, and frankly, I have not visited that area of the law to quite the depth, and it sounds like there's an interest in that. So I will make sure that I make a note to dive into that segment a little bit more. You bet. Okay. So the state and federal exchanges begin also in 2014, and this is a very interesting process. We have the opportunity to work with Melanie Curtis of Stoll Reeves, who is she's the legal counsel to the Employee Benefit Trust, and also one of the 8 governor-appointed members to the Exchange Board. She was going to present with me today, and we presented last year, you might recall, at this conference together. She's had some Exchange Board business this week, so she was unable to attend. She's been such a great resource, insight into the Exchange Board. Washington will be up and running. They have been moving forward quite readily, and we'll talk a little bit more about what the exchange looks like in just a little bit. So a lot of the next couple of, the next slide, patient protections. I know the Employee Benefit Trust has really been addressing these since, early, since 2011. So these changes are not required with our plans, but there have been public sector plans out there that have grandfathered themselves from not complying with these elements of the law, and they will need to comply, required to comply as of 1/1/14. I know some of the Teamster healthcare plans have grandfathered and not complied with some of these segments. They will have to as of 1/1/14. So if you have Teamsters healthcare, some of you may have been hearing about that. One thing that we do need to pay attention to, and I'll call you, is the 4th bulleted item down, and that is that there's going to be a leveling of the playing field regarding cost sharing and out-of-pocket maximums. So what this means is that when you have all plans have an out-of-pocket maximum feature. Your out-of-pocket is capped, and once you hit that cap, the insurance plan will pay 100%. So it's like stop-loss insurance. So what they're doing is that all plans will be required to have the deductible and all copays, including prescription drug copays, apply to the out-of-pocket maximum. This impacts the Employee Benefit Trust plan design. I'm certain that it also may impact those of you who are, self-insured. So this is a plan design that we're going to need to pay attention to. What I've asked our insurance carriers to do is to actuarially put a price value on keeping our out-of-pocket maximum the same, incorporating those copays. How much would we have to increase the rate in order to accommodate that benefit mandate? Hang with me just a second, Roger. So a price point. What if we were to increase the out-of-pocket maximum to absorb the copays and keep our rate of increase for that benefit mandate at 0? So what I hope to give you, those are members of the trust, and if you're not a part of the trust, I encourage you to maybe take a look at this strategy as well, that when you have to announce this benefit plan change to your unions, you have something to give to them. That's what I hope that we can give to you, is, you know, if we would have kept the benefit the same, this is how much more we would have had to increase the rate. Roger?
Well, I'm trying to figure out what the purpose of, if you add all of that, but yet each insurance can set their maximum, their own maximum, what benefit was that being put in there?
Yeah, so the question is, what benefit or what value is it to everyone when each plan can design their own out-of-pocket maximum? And the stated value in the FAQ that came out by U.S. Department of Labor in February that issued kind of this clarification mandate was that the term out-of-pocket maximum meant something different for every plan. They wanted to equalize what the term out-of-pocket maximum meant. So for instance, on our plan, we have an out-of-pocket maximum of $1,000, but the $10 office visit copay wasn't applied to the out-of-pocket maximum. You know, the $4 and $15 and $35 prescription drug copays did not go towards the out-of-pocket maximum. So to an employee's mind or to a layman's mind, that was kind of contradictory. Yeah, it's my out-of-pocket maximum except for, right? So the intention was that this is your out-of-pocket maximums for everything in your health plan, and then you go from there. Does that help?
I suppose, but it's still...
I'm trying to explain federal
No, I
Congress logic. I did my gosh darndest.
The end result is...
He's just different.
Okay. So anybody else have a question on that? Okay, great. So you'll see something come across your table on that. Automatic enrollment, that's been delayed. So we won't even go into that right now. And then I think, you know, further down, there's increased caps on rewards on health promotion. But, you know, rather, this is lovely, but how much money can you invest in health promotion to get a return? There's a point where, you know, money isn't necessarily everything. People are not necessarily always motivated to change by money. And so there's intrinsic motivation that we're focusing on now. And so I think, you know, with regard to the trust, that's where we're headed. This is a lovely support of health promotion. That's a great message in that regard. But it's also, you know, money to be invested in health promotion. I'm not sure it would necessarily be a wise investment. But that's for each plan to decide. And then the transitional reinsurance fee, I actually have a chart that talks about all of the tax or penalties or fees, however you want to identify them. They're embedded in the law and when they're effective. So I talked about quite a bit the patient-centered, the PCORI fee. That's the number one on the list there. That's implemented in 2013 through 2018. It goes up every year. It's intended to pay, as I said before, research and quality outcomes for healthcare. The transitional reinsurance fee is to kind of fund a level of insurance that is the reinsurance or the high cost claims and that whole market. So the goal of the reinsurance fee, which has been costed by the federal government to be $63 annually per covered life in 2014. It is going down each year from 63 to 42 to 26. So this is a 3-year fee that will be incorporated in all plans, whether you're fully insured or you're self-insured. You can't escape this one. This is a fee you will all pay. And actually what will happen is it will be embedded in your premium. Is how it will be addressed. okay? The health insurer fee does not apply to self-insured plans, and it is significant. It only applies to fully insured plan. It's a 2 to 3% premium increase, and this is actually to fund health care and some of those subsidies initially. There's a state exchange fee. Now, Washington has said that it's not going to charge a separate state exchange fee. Our neighbors down in Oregon have a very significant state exchange fee that will be implemented. So we lucked out here in Washington on that, I guess. Clinical trial fee, not much more information on this. It's definitely in the law, but there's no dollar point attached to it at this point. And then we have the high value healthcare tax, the Cadillac tax that's coming in 2018. We'll talk more about that. Yeah, Deanna? Thank you. Yes, I have quite a few slides to work through. So, okay, so here we go. The state healthcare exchange, and I will move through this actually pretty quick. The state healthcare exchange is intended to be an insurance marketplace that helps individuals and small business to access affordable health care. In Washington state, with the exception of small business, we actually had a model in place, and it was the basic health plan. If any of you are familiar with that. You know, this is a plan that individuals had access to health insurance on a subsidized premium basis. So it's funny, they basically moved the basic health plan staff from there to the health exchange is essentially what they did. And so the health exchange now is broader. It's in addition to individuals, it's also available to small employers. And it will be subsidized health insurance that they will have access to. It's initially, like I said, initially open to small employers, and they're identifying that small employer is under 50. It has the potential to go up to 100 if they so wish in the future. And all states are required to offer a state exchange. The blue states are the states that have declared that they're going to administer their own health exchange, and they're going to take that cost. The cost of administering an exchange is pretty significant to take on that responsibility. Like I said, for the state of Washington, we had a system kind of in place, so it wasn't something totally new we had to develop. The infrastructure, electronic infrastructure, was huge. That was probably one of the biggest things that Washington state had to address. The kind of vanilla colored states are defaulting to the federal health exchange. There are about 26 of them, and there are 7 that are kind of light blue that are doing a planned partnership. And so that's just to give you a feel for who's doing the exchange. The metal tiers, level of coverage, and then a catastrophic plan design. This is just an example that was issued by Kaiser because I don't believe as yet, and I keep on looking for it, they are close to getting their plan design ready here in Washington state. So this is just an illustration of what a plan design could look like. This is the bronze and silver level with regard to a benefit value of 60 or 70%. 60% is the minimum. And then deductibles of, from a bronze deductible of $4,300 to a silver plan 2 deductible of $650, and then out-of-pocket maximums that are very high. So you look at these benefits and say, holy cow, that's quite different than what our employees have access to. But to some here in Washington state, this is going to be wonderful coverage. This is a visual to give you an idea of the kind of household income that could be eligible for a subsidy. So if you're just an individual uninsured in Washington state, or frankly in the country, they have a chart that is basically about 140% to 400% of the federal poverty level. If you are in that blue range, then you will have access to an incremental level of federal subsidy, meaning your premium will be brought down to a level that is affordable for you based on your income. And the income levels at, let's say, 150% are $18,000, about $19,000 and $37,000 for a family. up to 400% eligible for a subsidy, 49,000 single income, up to 99,000 family income. So pretty, medium-sized income eligible for subsidies through the exchange. So what makes this all interesting, and this chart is really what I was talking about earlier about I'm not sure that our country is necessarily going to insure themselves through the exchange, is if you follow this chart, start here, do any of the following apply? Religiously opposed, undocumented immigrant, incarcerated, member of the Indian tribe, so we'll get further definition on that, etc. If any of those apply, yes, then you are not subject to penalty. But if the answer is no, you would be subject to a penalty if you did not insure. Then it goes down and say, are you insured? TRICARE, Medicare, your employer, the state exchange. If the answer is still no, you are not insured, the bottom yellow blocks is what you want to pay attention to. The penalty for not insuring in 2014 is $95. So I think that the penalty, many in the industry think and know that the penalty is not high enough. It does escalate as years go on. So this is what we talk about rolling impact to our trend line. It probably won't be initially in 2014, 15, or 16 because the penalty to insure as a private individual is just not high enough. It's almost just like a deductible, right? Why pay the premium when the penalty is so low? So employers for shared responsibility. So those of you who have 50 employees or less, and that's 50 full-time employee equivalents. So you take your full-time employees, we're going to talk about this a lot more in the next session, and your part-time employees to get up to a full-time equivalent. If you fall below the 50 employee line, you are not subject to these penalties. If you are 50 full-time employee equivalents or more, then you would be subject to what they call the employer pay or play. Okay? So it's a game. Pay or play. And so we're going to talk a lot more about this in the next section. I won't spend a whole lot of time on calculating this because I know that you have a lot of questions on this, and we're planning on making sure we address all of them as much as we can anyway. And so, but I want to get to the context of the pay or play, and that is that the employee is not eligible for the premium tax if the employee has access to minimum essential coverage, which is defined as 60% benefit levels. I'm kind of assuming that everybody has a benefit plan design that pays at least 60%. Would you say yes in your employer? Okay. So then also the other criteria is, do our employees have to pay any more for a single employee coverage? So single employee, keep that in mind. More than 9.5% of their annual wage. That would have, for a single employee, this is not family coverage. This is single coverage. Are there any employees that have to pay more than $130 a month for their premium for single coverage? I'm saying highly likely not. Would that be accurate, do you think? So if it's affordable and if you provide minimum essential coverage, you are not subject to the penalty. The problem comes about with regard to the variable hour and seasonal employees and how we provide benefits to them and how we work through some of those benefits, which we definitely have the ability to do, I believe, and still continuing to provide the services that you provide. But we do need to pay attention to it. So some elements, other elements of this particular segment of the law say that employers do not have to offer coverage to 5% of your employee population. So that's another little bit of an out, if you will. you only have to provide coverage to 95% of your full-time employees and their dependent children. The dependent children, you have to offer access. You do not have to pay for dependent children. Just provide access to, okay? But employees, it's another matter. Employees, you have to at least, keep their contribution keep their contribution below 9.5%. Does that make sense? Okay. And then if you, so if you did not offer coverage to an employee and they accessed the healthcare exchange and got a subsidy, you would pay a penalty of $3,000 or $2,000 per FTE minus the first 30. So let's say you're an employer of 100. You did not offer coverage to an employee who was supposed to be offered coverage. Let's say an employee that maybe works 9 months out of the year and ends up to be a full-time employee, but you did not offer them coverage. They ended up accessing coverage to the state healthcare exchange. You would be required to pay a $2,000 penalty on 70 employees. So 70 times 2,000, which is 140,000. Divided by 12, they would bill it monthly, and that would be the penalty.
So 2,000 per FTE per year, though?
Per year. Yeah, per year. Now, for some, that might be a viable option. But again, I think paying attention to all of this, the one reason I don't pay a whole lot of time on this is because I think as employers, we can be proactive. We don't have to be a victim of a penalty. And that's our goal for this next section. We're going to give the good news to you that we believe that by developing policy, by developing job descriptions and keeping to that we're going to be able as jurisdictions to not be a victim of a penalty unknown to us. Be surprised by one. So that's, I think, the good news in all of this. We have, as this type of employer, the ability to do that. And then employers who offer coverage, but it's not minimum essential coverage, it's a different kind of premium. But again, I don't think that applies to those people, those of you that are in the room. So that's the essence of this chart here, is that, as an employer, do you offer coverage to your workers? Yes. Does the insurance pay for at least 60%? Yes. And I need to be done, don't I?
Well, I just want to make sure now you know why everyone in the country wants to have Carol speak to them, right? Yes. And so you'll also, I'll do the commercial here because Carol's too proud to do it.
Oh.
You'll also understand why so many of us cities enjoy being with the Employee Benefit Trust of AWC. It's a great institution thanks to her leadership.
Oh, thank you.
So how about a nice hand for Carol?